Rohit, take it away.
All right. Welcome everyone to the 72nd session of virtual shadowing. Tonight's session is a specialty spotlight in trauma and acute care surgery with Dr. Huss. As always, you can reach out to us on Instagram at virtual shadowing or through our Gmail, which is virtualshadowing@gmail.com. These sessions will be recorded and posted to our YouTube channel, which is Pre-Health Virtual Shadowing. Next slide, please.
Try it. There we go.
Here's the virtual shadowing working group comprised of Reagan, Shayon, Taylor, Holly, Rachel, Miriam, Elena, Anirudh, Kiana, Aditya, and myself, as well as our 4 physician providers, Dr. Fowler, Dr. Morsetti, Dr. Salazar, and Dr. Reno. Next slide, please. Here are some of our upcoming sessions. So next week, we have pediatric emergency medicine. The week after that, we have an inside emergency medicine session. And the following week, we have a specialty spotlight in urology. Join us on Zoom or YouTube Live at 7 p.m. CST for these topics. Next slide, please. As always, we will have 2 Q&A sessions, one near the middle of the presentation and one at the very end. If you have any questions, please put them into the chat. Don't direct message them to either me or Dr. Huss because we may not see them. Put them in the general chat so that our team can collect those questions. And this session will last about an hour to 2. And now for a few words from Dr. Fowler.
Well, good evening, everybody. It's so nice to have you all here, all over 200 of you, almost 300 of you. Bless your heart for coming. Thank you for coming week after week. This means a great deal to our virtual shadowing working group. We've already sent half of them off to medical school, and we've got several more volunteers that are continuing to work with us. So we're just delighted to have you week after week. I got some numbers today, and it turns out that of the 71 lectures that we have published, which are available at virtualshadowing.com, we've had over 810,000 hours of viewing of our sessions by some 47,000 of you worldwide. So we're just delighted to be here. As you know, I'm on the admissions committee at UT Southwestern. We've had 5 meetings now this season, and we're seeing lots of applicants using virtual shadowing hours in their applications to medical school. And I'm sure that's also so for pre-PA, for pre-nursing practitioner, and other areas of healthcare. So we welcome you, and we hope that we're providing for you a product that is useful for you week after week. So Rohit, would you please introduce our wonderful guest this evening?
Our guest tonight is Dr. Huss, who is a general surgeon specializing in acute and trauma care surgery. And with all that said, please welcome Dr. Huss.
Thank you very much, Rohit. Thank you very much, Dr. Fowler. Thanks for the kind word and the introduction. So my name is Dr. Huss, and I am a trauma surgeon, general surgeon, and dealing with acute care and critical care. I work in a level 1 trauma center, which is Delray Medical Center, and also in St. Mary's Medical Center. Both of them are in the West Palm Beach and Palm Beach area in South Florida. We're pretty busy, and let me start with just a few disclosures. First of all, I'm a member of an ACEL consultant bureau. I also am a consultant for Dupuy Synthes, AtriCure, and 3M consultant. The topics that I'm going to be covering is a little bit of background, some case studies, and we'll do a day in the life of the trauma surgeon. So first things first, who am I, where am I come from, and why am I doing this? So as I said, I am a trauma and critical care, acute care surgery physician. I work in a level 1 trauma center, which means that we have residents and research, and it's in the South Florida area. I was born in Israel, born and raised. I came to the United States early 90s, and eventually got into medical school. I went to University of Miami Medical School. Both I did my PhD in biochemistry and molecular biology and the medical school in the same location. I did my fellowship in a Ryder Trauma Center in trauma and critical care. And then since that point on, we moved on and worked in a few hospitals. And as I said, currently I'm working in the South Florida area in the Palm Beach region. The reason for the why is quite obvious, at least for me. I like this, everybody works differently, and I prefer and I work best in areas that have literally organized chaos. So if you look at this picture, it may look very chaotic, it may look kind of strange and crazy, and there's blood everywhere, and it's messy, but there's actually an order. I know that any trauma surgeon that will take a look at this image, it will be extremely familiar to them. They may even predict exactly what has happened here, with a few exceptions, and there are enough clues to know what has happened to this person, at least potential and differential diagnosis type of possibilities. What did I attempt to do? And based on all that information. So I love this image because it literally depicts exactly why I chose trauma. It's chaotic, yet there is some sort of logic there. It's all organized and it makes sense if you know what you're looking for. Similarly, in this picture, this is not clearly to me, I guess not clear to everybody, but this is not in the operating room. This is actually in a trauma bay. It's a resuscitation area where everything first starts. So just a few things to note for somebody that is interested, let's say emergency room medicine. You will see here this yellow little pack that is a part of a unit that allows chest wall compression to be performed. You have a backboard that is used for transportation of a patient. Clearly, there's a lot of blood, so clearly something bad has happened. There was some penetrating wound of some sort, most likely. You can see some pads that used to be to resuscitate, to defibrillate a patient, and you can see an ambu bag on the top. That's a little blue ball on the top part of the window, so you know the patient was being provided air through that bag and most likely was intubated. So again, it's back to the why. Another clue is at the bottom right. If you look closely, you'll see a little wire, circular type of thing that has a little blue color. I don't know, do I have an arrow? I don't see an arrow. It's bottom right corner.
I think if you just move your cursor with a mouse, it should do it.
Yeah, but I don't see it on the screen for some reason.
Well, that's all right. You're doing great. And by the way, Nir, I've noted, I work in Parkland Trauma Unit, and I had an observation. Can you go back one slide? Do you mind? I don't mean to interrupt your talk. Right there.
Absolutely.
Every single thing, all the 300 people listening, every single thing was a moment that you see there was a moment trying to save someone's life. Every single thing, every bag on the floor, every drop of blood, every dirty sheet, that was an attempt to save somebody's life. Nir, I didn't mean to interrupt, but I find these pictures really moving.
Yes, because really it's exactly as you said. What's really standing behind this is a lot of blood, sweat, and tears, both of myself, the team that I'm working with, and obviously the patient and their families sitting outside. And you know that all this basically unfolds in a period of minutes to maybe an hour or two at the most, and it reaches some sort of a conclusion. The conclusion is always the same. It's either the patient survived or they didn't. From the moment they did survive, now there's another race for the second tier of trying to keep them alive. So it's very intense. And 1 second. Oops, going the wrong direction. Okay. But part of the why is also the end result. The end result is the people. And every single one of these people that you see here on the screen have a story. And all these stories are actually quite amazing. The guy in the center, for example, he was riding a motorcycle and he was hit by a car. He flew forward and he split open his pelvis in a way that had something called an open book fracture, where essentially all his guts spilled out from the bottom. And by I mean all his guts, I literally mean everything. He had a hole that was the size of a basketball that split open his pelvis. Usually that's oftentimes a devastating injury that the patient bleeds to death in a fairly short moment of time. There are very key interventions that have to occur in a fairly short amount of time to give that person the ability to even potentially survive. But the bottom line is to stop the bleeding. The young fellow on the right, he was riding a motorcycle. He was riding a motorcycle and a semi-trailer crossed the street, not paying attention that there was a red light, and he literally hit that trailer about 85 miles an hour. This kid was dead. He was very vividly, I arrived, it was 7:05 a.m. and there was literally a shift change. I was seeing a code taking place, and the trauma surgeon from the night before said, "You're up." And I went into the room and I opened his chest right there and then. We clamped the aorta, took him down to the operating room, did a few things. He was clinically dead for about almost 20 minutes. Luckily, we're able to maintain his oxygen saturation, which means that by clamping the aorta and trying to concentrate as much blood to the top part of the body while providing air to the patient and oxygenation, we preserve the brain. And ultimately, his only deficit after everything was said and done, he had surgery in his chest, in his heart, in his lungs, in his chest. Every single body product had surgery. And he has difficulties using his right hand, but other than that, he's back to normal, which is quite amazing. The two fellows on the right, the guy on the left part of the screen, the older looking gentleman, he's a nice fellow, was riding his bicycle as he always does. This guy actually was hit by a car, had multiple rib fractures, flailed chest, which is when you have a rib or a set of ribs that are broken in more than one place. And he was basically like putting Lego pieces back together. We reconstructed his chest. He had a temporary, some additional, let's say, abdominal injuries that had to be taken care of. And ultimately, he was back on his bike. He rode so much that he let me know one day I received a text, I finished going around the world, you know? So after such a devastating injury, he was able to pick up the pieces, go back to his life, and he circled the world in a distance-wise using his bicycle. Right there next to him is his wife, who just happened to be also a patient of mine for a totally different reason. In that case, it was a general surgery case that she had some severe abdominal problem that's called diverticulitis, where the colon has a small perforation, and we had to deal with that. It's oftentimes a life-threatening event, and there are many reasons for that I'm not going to go into it because that's a different discussion. And it's just amazing how many lives you touch and in what way they touch you back. So this is the why. Next slide. Okay, let me start a different tact here. And I just want to discuss just a little bit about how we deal with trauma patients. So when a trauma patient comes, imagine this. We first get a call, usually on a radio, saying we have 5 minutes or 4 minutes or 10 minutes, and a very basic description of a patient that's coming in. Let's say a 25-year-old, a motorcycle crash, and they tell us a GCS of 14, which means that they're a little bit confused. Maybe there's a traumatic brain injury. We'll discuss this in a minute. And some basic blood pressure and heart rate. And that's it. And now I got to come up with an algorithm based on that and start a certain differential diagnosis of where I'm going to go with this. Trauma is very, very regimented. The key is not to forget anything. When a patient first comes, we go through an algorithm called ABCDE. It's fairly simple. It's always the same. And this way you never forget. And everybody gets the same thing. It's very systematic. So what is it? A stands for airway. We check the patient's airway. If they're talking and screaming and cursing, that's great, because I know there's no problem with the airway, especially those that are screaming. It's perfect. I know that if, let's say, I get 3 traumas at the same time, the person that's cursing and screaming, most likely they have the least amount of problems that I need to deal with. So I leave them alone. Breathing, that's the next step. Are they breathing? What type of breathing is it? Is it shallow? Is it heavy? Is it fast? Is it slow? Am I thinking that there's an airway obstruction? C stands for circulation. Obviously, you check for pulses, you check for bleeding, you look at their heart rate, anything that has to do with circulation. D is disability. Now we actually look around and see, okay, what is broken here? Does he or she, any exposed bones, any exposed wounds, any bones sticking out, any fractures that are closed, meaning there are no wounds, but yet you can see clear deformity. Is the patient altered in any way? Are they not able to talk? Am I considering a traumatic brain injury? Is there a problem to their vision? Any sort of disability falls there. And last E is exposure. We exposed everybody. When a person comes in, we use these special scissors called trauma shears, and we cut all their clothes off. And the reason is because we need to see everything. We need to assess everything, head to toe, front, back. We need to see everything to make sure we're not missing some injury. Sometimes you have, especially let's say in gunshot wounds, small entry points that you may easily miss because a small bullet, let's say a 22 caliber bullet, may be just a few millimeters inside, and you completely missed an injury that is obviously potentially life-threatening. So A, B, C, D, E. It's simple. Airway, breathing, circulation, disability, exposure. For everyone, everybody gets the same, and it's always in the same sequence. Next is we assign a Glasgow Coma scale score for every patient. So it's a nice little algorithm. Everybody gets up to 15 points. So just for showing up, even if the patient is dead, you get 3 points. Obviously, it doesn't help them, but 3 points is the minimum amount that you can get. All right. And 15 is the highest. So what does it mean? We look at their eyes. Do they spontaneously open their eyes? That's 4 points. If they don't open their eyes, if I tell the person, open your eyes, will they do that? If they only do it not spontaneously, but to my commands, to a verbal command, that's 3 points. If they only open their eyes to a painful stimuli, that's 2 points. If they do not open the eyes, even to a deep painful stimuli, you get 1 point. Okay, so that's eyes. Then verbal. Verbal is up to 5 points. Are they oriented? Do they know what's going on? Do they know what's the date? Where are they? Do they know the president of the United States? I mean, obviously in the US, that's what I would ask. How well they know who they are? Are they confused? Oftentimes people that come in that are drunk, let's say, or intoxicated from alcohol or drugs, they might not necessarily be oriented, so they may seem confused. You get 4 points for that on verbal response. Do they have inappropriate words? Meaning you ask them a question and they form sentences, but the sentence doesn't make sense. You get 3 points for that. All these things basically give you an idea of potential traumatic brain injury or what is going on. Is it a concussion or is this person 100% okay, at least at this moment in time? Because another 5 minutes may pass and a traumatic brain injury that initially did not show itself may now rear its head and their Glasgow Coma scale score will now decrease. But as I said, 15 is the highest, 3 is the lowest. Just by showing up to a trauma bay, you get 3 points, okay? Just by showing up, it's 3 points. Motor, the most you get is 6 points. If you obey commands, you get 6 points. If you localize to pain, it's only 5 points, meaning if I withdraw for pain, you only get 4 points. If I flex due to pain, if I extend my arms due to pain, that's only 2 points. If there's absolutely no motor response, that's 1 point. So a person that comes in and they're, as I call, out of the program, completely just laying there, not doing anything, not even breathing, they don't open their eyes, they have no verbal response, and there's no motor response, they get 3 points. Again, just for showing up is 3 points. Another key thing that we use in this is a very simple mechanism to know at what point do we protect their airway. So at what point can a person not protect their airway? And there's a nomenclature that we use is GCS of 8, you must intubate. So if someone has a score that is 8 or less, we say they cannot adequately protect their airway, and therefore we intubate them. So in a very few seconds, you check their eyes, their verbal and their motor movements. You assign a quick score in your head, and you can guess and rely on this. It's very, very reliable. Tell you kind of where things are going. But primarily is I need to protect their airway, because remember, A, B, C, D, E, A is for airway. Airway is number one. You always protect the airway. Next. So with that being said, we started with the A, B, C, D, E. We assigned a Glasgow Coma scale. The other thing we do after the exposure and we check for the patient, a lot of things happen at the same time. This is actually, again, as I said, an organized, coordinated chaos. And even though it's chaotic, it's always performed in essentially the same way. The nurses in the trauma bay, they know their job, and it's my part as the trauma surgeon to be the captain and to let everybody knows what they need to do, when they need to do it, and how I want it to be done. And it's very important that to take command and to be the leader that everybody looks up to make sure that things are being done. Because when things are not being done, then lives are lost. We also have to obtain 2 large bore IVs to basically to provide access for medications, for fluids, etc. There's always a nurse that immediately one of their job is to go and obtain the IV. They know it. It's an well-oiled machine, and oftentimes I don't need to tell them what to do. They already know what to do. A lot of them have a lot of experience, but it's always up to the trauma surgeon if they want to change the algorithm in a certain particular way or to drive it one direction or another. The buck stops there. You're making the decision as the trauma surgeon, and everybody needs to listen to you, and you better know what you want to do. There's not a lot of time to make that decision, and oftentimes these are obviously life and death decisions, but that's what makes it, I think, so interesting and so rewarding to me, is the fact that you have this chaotic environment, and out of it, it's all very well organized in a very one-way focus with a one-way goal, and that is to save a life. And it works. It really does. We obtain x-rays of the chest and the pelvis. We use now ultrasound. Almost every patient gets an ultrasound. It's called a FAST exam, which is a focused abdominal sonographic exam. And we check their abdomen in all 4 quadrants. We look for bleeding. We check their heart. It's a very powerful tool in our hands to be able to know what's going on inside the body before even obtaining one single image. So the next step is, let's go and discuss a few cases to show an example. So in case number 1, MVC.
Hey, Nir, before you get started, you've got 330 kids around the world listening to you right now, not to make you nervous, but this is one of our best attended sessions in a long time, and this is terrific. Somebody wrote about that sternum fracture. Then they said, "I wonder if that hurts." I went, "Yeah, that hurts."
You bet it hurts. Sternal fractures are extremely painful, and actually, I almost consider it a hobby of mine to deal with sternal and chest wall reconstruction and injuries, because to me, it's very gratifying. You fix it and you have an immediate response of relief, especially on the sternum. You fix the sternum and all of a sudden you see a smile, literally from the moment they wake up, because from what was excruciatingly painful, just imagine every breath you take in a sternal fracture such as this, the 2 halves of the sternum, they kind of gnaw into each other. You try to turn sideways, the 2 pieces don't turn together. You try to breathe. With every breath, there's movement. It's very, very painful. If any one of you ever broke one single rib, you know how painful it is. So imagine breaking, let's say 5, 6, 10 of them, plus or minus a sternum. It's an extremely painful event that can be repaired fairly quickly. I mean, relatively within less than an hour, we fix a sternum, and it's an immediate gratification in the sense that the patient feels so much better fairly quickly. That being said, let me start with the cases. Unless there are any other questions, I'll be more than happy to answer them before we start.
We have a good question already that says, how in the world do you thrive in this kind of environment? Don't you know? Have you gotten used to this?
I think if you ask my family, they would say that I would definitely build towards that. It's again, the chaos is. I think you have to have the right personality for this type of environment. I think one of the amazing parts in medicine is the fact that it encompasses so many different fields that I believe that as a person, whatever your personality is, there is a sub field in medicine that is for you. You know, if you're the quiet type, then it can be pathology, you can be radiology. It's fine. It's quiet. You're by yourself most of the time. If you like more people interaction, family medicine is great. Internal medicine is great. I mean, there's something for everyone. So, and I think very quickly within the first maybe 2 years of medical school, that's kind of the key to try to figure out, I think, where do you want to end up? And that's where the rotations obviously come into play, where you would try to solidify that idea that you have. Am I really up for orthopedic surgery, or am I really a psychiatrist? I mean, I know it's diametrically opposing, but I've seen people that have switched from one to the other, which is amazing, because you would think, well, didn't you know ahead of time you want to be a psychiatrist rather than, you know, a surgeon of some sort? But it's amazing what people don't realize until they actually go through the motion and go through the rotations, which I think is what medical school affords. It's an amazing opportunity to really also discover yourself, and you then learn, because you will know very quickly if you like something or if you're not. And I believe that you should only pick something that you like, because otherwise you will not be happy. You'll be miserable. And when you're miserable, there's no way you're going to be good at it. So that's my take.
So were you a blood and guts kind of guy when you were a kid, so that you knew you kind of wanted to go to something like this, or did you sort of pick it up as you went along?
It's both. I wasn't necessarily blood and guts as a kid, but I would say that I always used my hands, and I like to tinker with things, build and fix. And then that passion kind of grew. And I was once in the operating room. I was actually doing my PhD, and I was in the operating room seeing a cancer operation with a good friend of mine at the time, who was actually a GYO surgeon. He was a gynecological oncology surgeon, and I needed tissue samples, and I was doing some research project that I obtained some tissue samples. And the moment I saw that, I knew, I knew that the OR is where I have to end up for sure. And then trauma just kind of solidified everything to me. It just felt right.
Nir, what was your PhD? What did you study?
PhD was in biochemistry and molecular biology. Basically, in my PhD, I used computers to identify new genes and then predict functionality, and then design biochemical experiments to then go ahead and try to test the hypothesis that based on whatever epitope that protein that is derived from the gene that I was working on, to try to predict its functionality. So design experiments that would then prove that what I think the gene does, it really does do.
Well, I'm sorry to interrupt. Please keep going. This is terrific.
So on case one is a fairly common event, motor vehicle crash. It's a restrained driver, meaning they were with a seatbelt, and there was airbag deployment. Okay. It doesn't matter the age. Let's say 40-something-year-old, in this case, a male, that comes in and to get a notice 5 minutes out, he's arriving. So what do we do? Where do we start? Remember, I said systematic approach. Don't miss anything. So A, B, C, D, air for airway, B for breathing, C for circulation, D for disability, and E for exposure. So we first check to see the person is breathing. Yes, they're breathing. They are in pain. They have what you see here is an X-ray. I'm sorry, a CT scan, but we do an X-ray. But even without an X-ray, you just touch and feel. Touch everywhere. Touch their legs, touch their arms, touch their neck, touch their chest, and feel. Anything that hurts, that's a potential problem. Make a note of it in your head. You're going to go back to it. You got to re-examine it and try to look carefully and figure things out. So that's what the primary survey. We always have a primary survey where we first, as the patient comes in, and I sometimes starts, if they come with, let's say, a helicopter, I oftentimes wait by the helipad. And as the patient rolls out of the helicopter, I literally touch everywhere very quickly. And within a few moments' time, I already have my differentials. I'm listening to the patient. I'm listening to what is being given to me by the paramedics on the helicopter as they transport the patient. And you put all that story together to try to assess and predict what is going on where you can't see. What can't I see? I can't see their brain. I can't see their chest, and I can't see their abdomen unless they're open wounds. But oftentimes, they're not open wounds. Most of the injuries are actually all closed. You don't have any clue from the outside, oftentimes, initially, other than maybe a hematoma here, a hematoma there. So touching is extremely important for the primary survey. Touch everywhere, feel for any bony defects, feel for any cavities, for any, for example, there's a classic identification for somebody who has multiple, let's say, rib injuries, may have something called a pneumothorax, which is a partially collapsed lung. When you have a lung that is injured, it releases air. It releases air outside the lung and it remains in the chest wall cavity. Sometime, if there's also a defect in the chest wall cavity, such as, let's say, sternal fracture or multiple rib fractures, air may percolate upwards. And when you touch the skin, it feels like Rice Krispies. It literally, if you can imagine, take a Rice Krispie cereal and smush it between your fingers. You can imagine that. Everybody knows what a Rice Krispie is. You smush it between your fingers, and that sensation is exactly what you would feel where you smash the skin of someone who has a chest wall injury along with a lung injury, and the air escaped the chest and it's right under the skin. You may not see it, but when you touch it, you feel it, you know immediately what's going on. So you know the next step is, oh, I probably need to put a chest tube there to evacuate the air, release the air, allow the lung to expand. So everything is a clue. It's like a detective work, but with a time stopper. You know, you have minutes to maybe an hour or two at the most to kind of figure things out if the patient is really sick. So we'll continue on this. That's the primary survey. We then do a few interventions, as I said, take an X-ray, obtain 2 IVs, left arm, right arm. If they have any open wounds, we may provide antibiotics, tetanus, do an ultrasound exam, also called FAST, and then decide, let's say, to take them to a CT scan, to then do a scan head to toe, if called for, to see for any internal injuries. When the patient comes back, we run through those potential injuries again as a secondary survey. Try to make sure I did not miss something. Did I miss a broken pinky? Did I miss a broken ankle? Oftentimes, somebody who is in a lot of pain, let's say in this case, got a sternal fracture, so much pain is in the chest, they don't care that their little toe is broken. That pain doesn't even faze them. So you may miss it and maybe only discover it the next day. That's
we call that a distracting injury, or somebody has
Exactly.
broken their thigh bone in half, which hurts like almighty hell, and their belly, which is actually bleeding to death inside their abdomen, they might not feel it so much.
Exactly. And that's exactly right. And things are missed. And as I said, in trauma, one of the key aspects is not to miss anything. So by being systematic, you'll reduce the chance of missing things. So therefore, the next day, as let's say the patient now is more stable, things have been quiet down, all of a sudden they realize, you know what, my pinky hurts. And if they don't complain about it, we should do what we call a tertiary survey. That's the third survey that is done the next day. Somebody needs to go and again, head to toe, touch the patient, ask questions, try to see and ascertain, did we miss any injury that patient has that was not seen yesterday? Because yesterday he had so many distracting injuries that he never noticed that his ankle is broken, that his kneecap is painful. He's got a patella fracture. So that is oftentimes discovered the next day. So that's one of the nice things also in trauma is it doesn't stop with the initial assessment. You have to reassess and reassess until you're sure that you have identified all the injuries. Let me continue. So in this particular case, that sternal fracture is not just, as you saw in the previous image, that looks like a oblique type fracture. This is a transverse. This would be longitudinal. And in this case, it's an oblique type fracture. It's also depressed, meaning it's pressed into the chest wall. So that shows here. So very interestingly, there's a hematoma there. This is an image from a CT scan looking on a patient slicing this way, okay, going in side view direction. We call it sagittal view. So in a sagittal view, you slice the person basically up and down like so, okay? And you can actually see that that fracture that was oblique is not just oblique, but it's also depressed with a hematoma. And you can actually imagine that with each breath, the two ends of the sternum kind of dive into each other. And in this case, the part that is the top part dives into the chest and can actually hurt what? What's below the sternum? It's the heart, okay? The heart is there. The aorta is there. There are a lot of vessels. It doesn't take much, one injury to any one of those things, and you have a few seconds to deal with or it's death, right? It's easily imaginable. You can't, it's not that difficult to predict that. I wanted to show here a video of when we repair it, how does it actually look like? You can actually see the two parts move, right? Now that, it's clear. Before, on the CT scan or the X-ray, it's one way. But when you actually see it with your eyes, it's obvious. There's no doubt in your mind, this is not right. That's not gonna be okay. And it is not okay. You can not necessarily fix it, and oftentimes it heals. It may take a few months. It will be miserable a few months, or we can take 1 hour at a time, put a titanium plate there, repair it, and you're done. The patient leaves the next day, and that's it. There's really nothing more. There's not even a restriction other than don't take a shower for a day. That's it. So back to this person, this is how it looked like before. As you can see, the oblique fracture, in addition to it's a depressed with a hematoma. With a simple 1 hour operation, we dealt with this issue and it's done. Nothing to think about. The patient goes home, they go back to their life. This is the repair. The repair in this case is 2 sternal plates going in a parallel line, basically kind of like train tracks. And the reason I prefer this method is if in the future, this person needs to have an open heart surgery, which oftentimes at that point you need to split open the sternum, you can imagine that that little distance in between those 2 plates, I can run a saw in between and open their chest fairly quickly without any interference from the hardware, as then I need to open it to access the heart. So it allows you still to maintain quick access to the heart if needed, which also brings up to a point of planning. The devil is in the detail. I'm sure everybody has heard that saying. It is so true in medicine. I think everything we say, everything we do has consequence. Any medication you give has consequence. Even though oftentimes you don't think much, I bet that for some people, if they have an allergy and if they have a severe allergic reaction, there can be dire consequences for that medication. So it should never be taken lightly. Every decision has a potential consequence. And I think that has to be internalized. You have to understand it and realize that what you say and what you do may make a difference in someone's life for the better or for the worse. It's not just true for trauma. It's not just true for surgery. It's true for any field in medicine. If a pathologist uses the wrong word on a report, that may cause a person to have surgery versus to not have surgery, and then let's say deal with the consequence of not having surgery because the pathologist didn't spell a word right, or the dragon dictate didn't write it down, and now a cancer was missed. So let me stop here after the first case.
Nir, this is terrific. We got some very interesting questions that have come up. For example, will you go back in and take those plates out one day on those sternal plates, or you leave them alone?
We normally leave them alone. There's no indication to take them out unless it's infected and for whatever reason it's not amenable to antibiotics and it's a persistent type of infection. So usually only due to reason of infection, I would go back if it's a reticent infection and I would consider removing the plates. It's very rare, but sometimes it is necessary.
Now, on to trauma in general for the students, and you've got 330 students listening to you, Nir, worldwide. We're so grateful to have you. An adult has about 5 liters of blood, which is 10 units of blood in the vascular space in the blood vessels. You know, an artery that's been cut can bleed a half a unit or a unit of blood in a minute or two. And so the point is that a trauma surgeon has got to move fast when the patient is bleeding. Would you comment on that?
Yes, of course. So normal cardiac output when we're sitting and not really doing much, depending on the person, maybe 2 liters per minute, 3 liters per minute. When you're in a stressful situation and your heart rate increases and all the endorphins kick in, you're racing and you may be 5-6 liters per minute. Okay, a gallon of blood is 4 liters. So an average 70 kilograms person has about 5 liters of blood. So just a little bit over a gallon. If your heart is pumping 5 liters a minute and you have 5 liters, technically, if let's say you have an aortic bleed, you may bleed in 1 minute your whole body volume. So just think about the time. It's not a lot of time, okay? A femoral artery bleeding takes probably about a minute to bleed a liter. So you have 5 to 10 minutes at the most to do something before it's game over. So the time scales are minutes. They're not hours, they're definitely not days. They may not be seconds, but they are minutes. But if you're dealing with minutes, then every second counts. Then everything that we may do to prevent bleeding makes a difference. And that's why there is the campaign to use tourniquet, to stop the bleeding campaign, which I encourage anybody to take a look at, and you can Google it. And there are many places where you can actually get simple training that will end up as life-saving procedures. But the bottom line, it's a mechanical problem with a quick mechanical solution, at least initially. Anywhere that you have a bleeding, you want to stop it. So how do we stop it? The best thing you have is your fingers. There's nothing like an educated finger. You don't need dressings. You don't need anything fancy. You just need an educated finger in the right place. And sometimes all it takes is a finger just on the artery and just hold pressure there. That's it. That will save a life until the person can get the care that they need. You don't need much more. Maybe 2 fingers if 1 finger is not enough. But
this is so important that actually the American College of Surgeons, together with emergency physicians and others, have organized a worldwide campaign called Stop the Bleed, which is direct pressure on bleeding wounds and or the application of tourniquets. Because if you've got a spurting arterial wound, let's say somebody slashes their arm deeply and they have a spurting arterial wound, they can bleed to death quickly, and you have got to stop that bleeding.
Um, one of the perfect examples that is in my mind that just popped in is a very unfortunate case of a 41-year-old male. It was 4th of July in the United States. And this is a day where there are a lot of fireworks, and he placed the firework and it prematurely exploded and lodged in his groin. So it lacerated his femoral artery and he bled. And the problem was that there was nobody there to literally just take his pants off and put a fist there or put a finger there or do something to stop that bleeding. By the time I received him, it was too late. There was nothing I could have done. He was dead. And such a simple solution just to stop the bleeding, place two fingers, oftentimes, because in his case, the artery was exposed. It was completely out. We could see it. That's all it would have taken to most likely give enough time to allow the patient to be transported and then a surgeon to go and deal with the problem and save him.
So Nir, let me see if I understand something. You mentioned A, B, C, D, E. Make sure the airway is open so that air will move. Make sure they're breathing, that they are moving air. Assess the status of their circulation. D for disability, their neurological issue, and then expose the patient so you can see where all they're injured. Is that also sort of the order that you treat the things? For example, the obstructed airway first, the patient who is not breathing, the patient who has lost a pulse. Is that sort of the order about how you treat these things?
Yes. If a patient is breathing or at least attempting to breathe, but the airway is not patent, meaning there's something blocking the airway, then it's not useful. So always the sequence is always A, B, C, D. Airway is always first. So making sure that the airway is patent, meaning open, that air can be moved in and out of the trachea and into the lungs. Then make sure that they're actually breathing. Are they breathing on themselves? Are they actually oxygenating? And if not, do we need to intubate, meaning to place a tube in their trachea to connect them to a breathing machine to allow oxygen to pass through artificially, not oxygen, but air rather. C for circulation. Are they bleeding from anywhere? Do I need to stop the bleeding somewhere? Because if they're bleeding, they will, if they're not stopping the bleeding, they will die. So C is kind of like it's intuitive. And there are some instances, obviously, if it's massive amount of bleeding, you may consider in certain situations to deal with that first, obviously, before airway and breathing. But I will leave that's out of the scope for this discussion. So the classic way is airway, making sure the airway is patent, breathing, that the patient is actually moving air on themselves. If not, they will require intubation. C for circulation, making sure that there's blood flowing, that the heart is actually moving. D for disability, is there any neurological injury? That's where we use the Glasgow Coma scale score. If the GCS is 8 or less, you must intubate, okay? Remember, it's composed of the verbal responses, motor, and vision. 3 scores, and just by showing up, you get 3 points, no matter what. So the lowest is 3, the highest is 15, and the cutoff for intubation is 8. It's very systematic.
I like to put it that the Glasgow Coma score of a rock is 3.
Yeah.
Their eyes are closed. They are not withdrawing to pain, and so on and so on. This is terrific. And for the students, a quick way to remember the Glasgow Coma score is eyes, verbal, motor 456. It's EVM 456. Well, Nir, I've been hogging your time, and Rohit has got the list of questions, and we've already got dozens of questions from our students. Rohit, why don't you lay a couple, 3 questions on Nir, please?
Sure, we've got quite a few questions. One question is about the Glasgow Coma scale again. So does this same assessment apply to unique populations, for example, children or patients with pre-existing conditions?
It applies for everybody the same. So the only caveat is a person that is intubated obviously cannot verbalize. So at the most, they'll get 11, and then you have to designate it, let's say T, some sort of a designation that says that they're intubated. But otherwise, it's basically the same, with obviously the exception that neonates and babies, they can't exactly talk necessarily. So the eyes are the same. The motors may not be the same because they're not necessarily going to obey commands. So this doesn't really work the same for, let's say, somebody below the age of 2. But I will leave that, again, that's a separate discussion and out of the scope here. But you obviously have to have a person, let's say age 2 and above, that has some verbal skills. Below it, it's a little bit muddled, and that's not for today.
Thank you.
You know, Nir, one of the things that takes so long for the trauma surgeon is to recognize the subtle things. For example, the patient who has ruptured a lung and now they have positive pressure in the chest. They're in shock, they're cyanotic, they're blue, and they have distended neck veins. And to be able to notice that this patient actually has an additional problem that's quite unique, describing, of course, a tension pneumothorax or a pericardial tamponade. And I didn't mean to get off on anything, but just the fact that this is a hard business. So anyway, please.
I see it akin to, again, detective work on steroids, so to speak, because you take as much clues as you can and everything has a place, everything makes a difference, and everything can count and make a difference in the end result, which is someone's living or dying. So such a subtlety, as you said, as distended neck veins, you can easily miss it, especially, let's say, if a little bit overweight person, you may not realize or appreciate it as much. A trachea that is slightly deviated to one side may basically be the telltale sign of a tension pneumothorax. Why is it deviated? Because the lung is collapsed. There is an injury to the lung. With each breath, there's escape of air into the chest, let's say on the right side of my chest. And with each breath, it pushes everything, the mediastinum, including my heart, my trachea, and the left lung, from the right side to the left side, slowly to the point that my trachea is deviated. You gotta act fast. Something has to be done. Oftentimes, in this case, it's a chest tube, but the point is really not this specific. The point is that you're right, that everything can be a clue to something that's going on inside. And the eyes don't see what the mind doesn't know.
Some of these patients are so complex. For example, they can have pressure built up in their lung, a tension in the thorax, and yet they're bleeding to death, so they may not distend their neck veins. Tough, complicated patients.
Correct. And everything can happen at the same time. I mean, the other thing in trauma is, since it's not elective, you have the privilege to take care of a person head to toe, meaning I can take care of head injuries and at the same time deal with a heart injury, a chest, lung, extremities, bleeding vessels, liver injury, take out the spleen if needed, fix the bladder, take out an ovary, repair a uterus, deal with the bowel, and fix their toe. All in the same person, all in the same time, and kind of like in that sequence.
We had a good question a while ago about, are there differences in different patients? And one of the things I pointed out was gender differences. Women have a uterus, they could be pregnant, they could have taken trauma to their uterus, and they could be bleeding to death because of bleeding inside the uterus. Men don't have a uterus.
Correct. Actually, along that line, one of the things that we do is we obtain blood. When a person comes, one of the first things that is done is blood is being obtained. And the most important study, if I can choose one thing, would be a type and screen. So I know what blood type they are. And if I suspect bleeding, if I suspect that they need blood, that information gets carried to the blood bank to allow us to release blood as soon as possible. Now, that being said, we always have in the trauma bay a few units of blood, platelets, and fresh fluorescent plasma that we can use immediately. And the other thing is that if I don't have a type-in screen, and let's say it's a 11-year-old boy and he's bleeding, and I decide that I want to give him blood, and the blood bank says, I am sorry, but I only have O positive blood, it's okay. O negative is the universal donor, but the chances that an 11-year-old boy will ever get pregnant in their life is close to zero. So O positive blood is okay to give to males if we don't have O negative. If it's a female, then you can make the argument and therefore reserve the O negative for a female because she may potentially be pregnant at some point, if not today. So yes,
Nir,
yeah,
it's interesting to watch things change. When I started training in the 70s, we gave whole blood, and then we did pack cells, and then we added from pack cells, we added back platelets, and then we added back platelets and fresh frozen plasma, and now we're back to whole blood again.
Yes. Yeah, actually, it's interesting that the debate as far as what is the best resuscitation fluid has still not been resolved, so many years out. And there's still discussion and data and papers that are being described and presented every month dealing with issues related to what is the best resuscitation fluid. It's
no question. And when I was a kid back in the 70s, mid 70s, I was doing my surgery. And we honestly thought in those days that you could not give enough crystalloid solution for the students, that's Ringer's lactate or normal saline. You couldn't give enough to dilute the clotting factors. Well, we know today that is not true.
Oh, yeah.
And we're still looking for the best resuscitation fluid.
Absolutely.
Maybe one more question, Rohit, and then we'll let him get on.
Sure.
Sure. One more question. In your experience as a physician, have you gotten to a point in your career where things don't really surprise you anymore, in the sense that you sort of know what sort of cases you can expect, or does every day still bring in something new and different?
I think for the most part, there's always something that surprises me. I'm always surprised from the fact that I am surprised, meaning even though you think you've seen everything, humans are able to surprise you. And one of the best anecdotes for that I like to keep is something to do when IBM first came out with the CD-ROMs. Some people complained that the cup holder doesn't work very well on the computer. And it just shows you that you thought about every potential way that a human being can deal and screw up the CD-ROM, but they still didn't think about the fact that somebody would think that this is a cup holder. So as much as I think I've seen everything, there's always something you have not seen. So there's always something that is new and different. And that's part of why I like it, because number one, you don't know what you're going to get. It's always different and it keeps it fresh. And therefore you also have to be on top of learning what is the latest information on every single organ in the body, organ system, and how to deal with injuries or medical issues pertaining to that. Because trauma is not just surgery in the trauma. A patient may come and has pre-existing disorders. They may have diabetes, they may have blood pressure issues, they may have cardiac problems, kidney problems, or a plethora of other things. So you really need to be kind of like a wholesome type physician and think about the medicine from all aspects, which is, again, another thing that I enjoy because it's completely all encompassing.
So near my world at Parkland was semi-paralyzed due to COVID. I would imagine you're so accustomed to operating on people with hepatitis C, HIV, tuberculosis, and so forth. I would imagine that the world of major trauma resuscitation probably didn't change a lot, did it, with COVID?
It did not. I mean, we obviously had those suits, the PAPR suits that we used initially. And that was pretty much the only addition, I think, that we added at the beginning before we had the rapid tests. But since the point of the rapid test, I know what I'm dealing with, whether it's a COVID positive patient or not, when we go to the OR. We added smoke evacuators and all sorts of filters to the breathing circulators that remove viral particles. So that was added, but essentially not much has changed. I can say that from my perspective, when COVID in South Florida was at its peak, one thing that did change was initially the number of motor vehicle crashes decreased, but because there are not that many cars in the road, we noticed much higher acuity for motor vehicle crashes. They were much worse. And the other thing was a lot of domestic violence that before that was, let's say, at a certain level, has increased significantly.
Neil, we've been going exactly an hour. Do you need a sip of water or take a break for a moment, or you want to keep on?
I can keep on. Yeah.
Okay, well, take it away. Case number 2.
Okay, so in case number 2, we have a 28-year-old guy driving a motorcycle, MCC, and he crashed. So motorcycle crash. He was helmeted, although he did have a TBI, which is a traumatic brain injury. On arrival, his blood pressure was 88/52 with a heart rate of 128. So first thing, let's stop there. You have a young person with a helmet on, motorcycle crash, and a low blood pressure with a high heart rate. Anything above 100 is considered what we call in medicine tachycardia, meaning it's a higher than normal, a higher than expected heart rate, and there's a reason for that. It can be anywhere from anxiety, but bleeding will cause that, fever will cause that. So then the blood pressure is another important tool. It's 88/52. It is low. It is lower than normal. And low blood pressure with a high heart rate is oftentimes what the body does in order to compensate for active bleeding. So you have to think in a trauma, oh, maybe this guy is bleeding. Maybe he's bleeding in the abdomen. I'm not aware of it. Maybe he's bleeding in the head. Something is going on in addition to just being excited that his heart rate is high, his blood pressure is low, and the one thing that can kill him now is bleeding. So you immediately try to direct everything towards potential for bleeding. Now, he is confused, GCS of 14. So as you remember, I said GCS of 15 is the highest. 14 is a little bit confusion. It may be alcohol that I'm not sure yet, but it also may be a traumatic brain injury. The fact that somebody wears a helmet does not preclude a traumatic brain injury. When someone goes from a speed of, let's say, 60, 70 miles an hour, 50 miles an hour to 0 in a very short amount of time, the brain continues to move forward and gets squished against our skull from the inside. That by itself is enough to cause a traumatic brain injury. That is enough to cause intracranial bleeding, to cause bleeding inside the head, to cause a brain injury that will cause someone to be confused, to have a lower Glasgow Coma scale score. In addition to that, saturation is 90% on room air. A normal person should be about 98, 99, 100% on room air. A 90% saturation of oxygen on room air tells me that there's something going on with their breathing. They're either not moving enough air, there is an obstruction, or a partially collapsed lung, fully collapsed lung, but there's something going on with their breathing. Or that they lost so much blood. We like to think of blood as having oxygen carrying capacity, meaning this is a little molecule that runs and circulates in our body that binds to oxygen and moves it all around. If you don't have enough blood, you're not going to be saturating enough, so your saturation will be low. If you're bleeding so much to the point that your saturation is low, you're in dire straits. You're bleeding to death. There's another tool that we use oftentimes. It's called an ABG. It's arterial blood gas. It's a great tool, and it can tell us a lot of things about what's going on. It measures pH, it measures levels of CO2 in the blood, it measures levels of bicarbonate in the blood, and it gives us oxygen, amount of oxygen dissolved in the blood, and something called the base deficit. All these together, again, out of the scope of this talk, but the point is, and the ABG that's showing there with a pH of 7.31, where the normal pH is around 7.4, so it's a little bit lower than 7.4, and that 0.1 difference may seem like a nothing, but it's considered acidotic. Our body is such a fine-tuned machine that we try to strive to reach always this equilibrium of neutral pH of a 7.4. Anything above or below a 7.4, even a 0.1 is a big deal. Something is wrong, something is going on that should not be happening. And in this patient is not oxygenating very well. He's got a base deficit of -10 on an ABG. A large base deficit goes, for example, with alcohol intoxication, but also with bleeding. Bleeding is always first. We can deal with alcohol intoxication later. So a large base deficit of -10, along with a low oxygen saturation, along with hypotension, low blood pressure, 88/52, and a high heart rate, 128, also called the tachycardia, you gotta, and a motorcycle crash as the mechanism, you have to think of bleeding. Then as we survey the patient, as you remember, we do a head-to-toe assessment, primary survey, secondary survey. We notice that he has an open left leg tib-fib fracture. What does it mean? Tib stands for tibia, fib stands for fibula. So the tibia and the fibula, these are the two bones in the lower leg, are fractured and they're open, meaning they're open to the air. A FAST exam is positive. FAST is focused abdominal. It's an exam that we use an ultrasound to look inside someone's abdomen and to identify potential for bleeding. It's positive when we see fluid in the abdomen and then we are concerned for bleeding. So take this picture together in a few seconds in someone's head and say, you know what, this guy is bleeding. And he's got this type of an injury as you see here. So motorcycle crash, you can literally see his bone. In this case, it's the tibia that's exposed. His ankle is broken and he was bleeding from there. Maybe right now he's not bleeding because some of the arteries and the veins have collapsed and retracted, but he may have bled a lot at the scene, which can explain what's going on with him. Or
yeah, on the middle picture, his toes are kind of blue too.
Yes, because they may be dead. You know, he's not getting blood to the foot. So first things first, after doing A, B, C, D, you know, checking the airway, checking the breathing, the circulation, disability, as I said, it's exposure. If you see that he has pants, they're gray and they were cut in half and you can see them split open. They may have easily hide this injury if you do not cut the pants open. So part of the exposure is also not to take the clothes off, but to cut them off, because certain injuries you don't want to disturb, especially let's say spine injuries. You want to always think of spinal precautions. Someone who has a cervical spine injury may remain paralyzed for life if we try to, let's say, remove their shirt rather than cut their shirt off. All these things make a difference. In this case, you can see on the right side the X-ray of how this looks like. Second. And on the next image, you can see it after we reduced it by the bay side, meaning in the trauma bay. The picture all the way to the left shows, let's call it an AP view or front view, make it easy, where you can see to the left, the larger bone, that's the tibia, and to the right, the smaller bone, that's the fibula. Both of these are bones in the leg, and this shows the ankle. It's fractured, but it's been reduced by hand. Literally, we took the leg and put it back to its place and pushed the bones in place and then checked for circulation again. Oftentimes, those blue toes then become red again because now the artery that was compressed, bringing blood to the foot, all of a sudden now is open and able to bring blood to the foot. So by literally reducing the leg, you just saved someone's foot potentially by allowing blood to flow into it. Obviously, this person is going to need surgery, but he may have other life-threatening injuries that this is okay that we can leave for now. We reduced it. It took literally 10 seconds, and we kind of set it and forget it for now and continue our examination of the patient. Because remember, he had a heart rate that was high, a blood pressure that was low, and an arterial blood gas, an ABG, all pointing to the fact that there's bleeding. And the other clincher here is this plus FAST, that positive FAST exam. It's an ultrasound exam that we look at all four quadrants of the abdomen and identify potential fluid. Initially, fluid in the abdomen is most likely blood until proven otherwise. So therefore, the next step for this patient is not in a CT scanner, is not in a hospital, in any other place other than in the operating room. So at that point, we go to the operating room and we explore. We do a exploratory laparotomy. So then, sometimes there are surprises. What you see here is an exploratory laparotomy. This patient was actually bleeding from their spleen, and that's what you see on the right side. The spleen was shattered, it was actively bleeding, and it was killing the person. So we had to take the spleen out. The spleen was taken out very fast, very quickly, and then we discovered an incidental finding in this case, where you see here bowel. It's a beautiful picture of intestines. It's a small bowel in this case. That's what you see in pink or red, whereas the yellow is something called the mesentery of the bowel, which connects the bowel to the aorta, essentially, ultimately, to all the blood vessels, and the lymphatics run through this yellow material, this fatty looking material called the mesentery. It brings the blood to and from the intestines. Interestingly, in this person, we saw a surprise, which is all these diverticula. Diverticula are out pockets of bowel. This person has had thousands of them. That is not normal, and that predisposes a person to other issues. It could be cancer, it could be perforation. There are many reasons for that. So you also need to be prepared to accept and find strange things that you didn't expect that have nothing to do with the trauma. This is something that he was born with, nothing to do with the trauma. But now that you're there, you may not need to deal with it today, but you need to let him know for the future. And it's back to this little fact thing that the eyes don't see what the mind doesn't know. And the key is knowledge. You always have to read, you always have to kind of expand your knowledge base and never stop learning. Because if you stop learning, you become stagnant. And in medicine, that will cost someone's life. May not be today, but it may be tomorrow. Next. This is an example of how the chest looks like. What you see here is ribs that are fractured, and as the patient is breathing, you can see that they're moving into the chest. So that's what we call a flail chest, where the person in this case is laying on their side, and with each breath, you can actually see the chest collapsing. And those bony fragments are so sharp that they also lacerate the lung. So that's how you get collapsed lung, as the air escape. In addition to that, they bleed. Underneath every rib, there's an artery, a vein, and a nerve, and you can bleed inside the chest. You can die from that. Again, this person, motorcycle crash, he has more than one injury. He had an injury to the chest, he had an injury to the ankle, he had an injury to the abdomen. All of that needs to be identified in a very short amount of time, figured out, and you have to have a plan, a game plan of how to approach it, what to fix first, what will kill him first, what to fix second, and come up with a plan and deal with every single injury in a fast fashion. It's not the time to open up a book and read what is the latest. You have to have the knowledge already ready to go. This is after the repair.
That is absolutely incredible.
So what you see here are these titanium plates that actually repaired. You no longer see this motion, right? This, oops. You no longer see this motion. That has been completely repaired. You can see here, it's very stable. You don't see any movement. The patient is still breathing, but the chest is fixed.
Hey,
Yeah.
Nir, it's not obvious how sharp those broken bones are, but I mean, they are like broken glass. Would you comment?
Yes. So I always double glove, and I can tell you that during chest wall repair, I often go through multiple glove changes because they get ripped. For sure, the outer gloves, I may sometimes go through 5 or 6 pairs because those sharp edges cut them apart. It's extremely sharp. So it's so sharp that you can imagine that if a piece of bone that is as sharp as broken glass is inside the chest, with each breath, as the lung expand, it can get cut. So oftentimes, one of the other things that needs to be done is repair lung tissue if necessary. So again, it's back to the fact that I think doing trauma is you kind of like the jack of all trades, so to speak. You got to deal with all sorts of injuries, whether it's dealing with bones, so a little bit of orthopedics, whether it's the heart, so cardiothoracic surgery, some neurosurgery, some general surgeries, colorectal, it's everything at the same time.
So near that chest wall right there took an enormous amount of energy, a blow to break those. Can
Yes.
that trauma be converted straight through to the lungs underneath and bruise the lungs and so on?
It does. So again, if you look at an X-ray or a CT and you see these fractures, you will also notice what we call lung contusion, where the lung in the inside, if the person was in a motorcycle riding, let's say 50, 60 miles an hour, 80, 100, it doesn't matter how fast, all of a sudden they stop. The lung continues forward and hits the chest wall from the inside. The lung looks like a sponge and it completely gets squished and squeezed and injured. So you have what we call lung contusion, where often it gets filled up with blood or fluid. And when that happens, you essentially kind of drown because you're not really exchanging oxygen and carbon dioxide with the blood in an appropriate manner and with the air as the air comes in and out of the lung. That's the problem there. So yes, absolutely, there's lung injury. There's lung injury to the parenchyma itself, meaning to the actual lung tissue. And there's also lung injury from the bony fragments that cut the lung. There's also lung injury because sometimes when something moves fast, it can literally shear off and break. So it can bleed, it can lose air. The energy gets also transferred to the heart. The heart also gets contused. The heart is a muscle. So it can get hurt and you can get arrhythmias at the time of trauma that may or may not go. The great vessels can injure. An aorta can rupture and tear due to a fast conversion of momentum from going fast into stopping in a very short period of time. The aorta may continue to move forward and then it literally rips at its attachments to the thoracic cavity. It is a common injury.
And then, of course, the liver and spleen sit right under the diaphragm, right next to those ribs. You break those ribs, they can poke holes in the liver and the spleen, as in with this patient.
And they do poke holes and then things bleed and people die. So again, you put all this together and you come up with a plan of who comes first. But the key is stop the bleeding. After you did A, B, C, D, and you stabilize the patient to some extent, or even if they're not stable, but you went through that algorithm and you decided that the patient needs to go to the operating room, now there's a whole other set of decision making. Which cavity do I open first? Do I repair the lung first? Do I go through the abdomen first? Do I deal with the leg injury? Again, out of the scope of this particular program, but that's why it takes many years to come up with those decisions in a fast-paced time, and then come up with a plan, stick with it, and do it, and save a life.
Can I also comment? Patients change. They may come in and look fairly stable, and then their pulse goes up, their blood pressure slips down. They actually change, and I think that's an important thing to point out.
Absolutely. Actually, just recently, I had an issue that I felt that the team did not appropriately, let's say, realize what we were dealing with. I saw a person that everybody thought they were stable, was a young person. And in my mind, they were not stable. They're actually dying, except a young person can compensate for a significant amount of time until their body cannot compensate anymore for the loss of blood, and then they crash immediately and literally die. So again, it's back to the eyes don't see what the mind does not know. It's your job to make everybody alert to the fact that even though the person looks okay and they're talking and they're fine, they're actually dying in front of you. And everybody has to act in a very deliberate, specific manner and do what needs to be done in the most efficient way and go fast. Because in my mind, that patient needed to be in the OR, and every minute was a minute spent that they were not in the OR and I was not dealing with the injury. And in this case, it was absolutely the case. The person was bleeding, and it was more of a kind of like a gestalt type feeling where you see something together, or you saw just something done enough that alerted me to, I think there's a much bigger problem here than what everybody's thinking, that this person is okay. And usually it's a feeling when somebody first comes in the first few minutes that you can kind of tell. Sometimes we're surprised, but with enough experience, you can kind of tell now where a person is going to end up. I think it's very rare that I'm surprised that I don't know from the get-go almost that I'm going to take this person to the OR. Usually I do know.
Nir, there was a good question that came up that Maddie asked that says, you have other specialists come in, plastic surgery, OB-GYN, orthopedics, others that may join you in the OR when you've got a very complex patient?
Absolutely. So trauma is a team event, meaning there are a lot of people that need to be available. If you think about it, I need a radiologist to be there 24 hours to help me read the films, okay? In addition to nurses and all the ancillary people. Somebody has to bring in the blood. Sometimes somebody loses a lot of blood and we call for a massive transfusion protocol. I may go through 100 units of blood. Well, you have to have a person that literally will run to the blood bank, have a blood bank ready, people in the blood bank ready to thaw out all the blood that is necessary, type it, cross it, and send it over to me in packets. And I may go over 100 units. I may need to call a neurosurgeon. And as I'm dealing with the abdomen and chest, let's say, they will fix bleeding in the brain. I may call for a plastic surgeon to help reattach an arm. We had a recent case where somebody was hit by a train and the train took their arm, and the arm got stuck on the train, and it took a few hours for police to stop the train. I guess they didn't realize it. A few hours down the road, get the arm from the train and then drive it to us in an attempt to reattachment. It was too late, but the point is, I had to call it was not actually my case, it was one of my colleagues, but a plastic surgeon was called, came in, was waiting for the arm to come. It was unfortunately too late for them to do anything, but a 24-hour basis, different specialists needs to be available. Interventional radiologists need to be available,
Hey, Nir, you brought up the issue of what's the most amount of blood you've ever given a patient, just if you can ballpark?
Probably about 120 units, which is more than multiple times going over their blood volume. And I'm miraculous that they did survive it.
10 times more.
Yes.
And it was interesting. The news this morning, one of the journals was talking about the fact that the American Red Cross said that our blood bank levels of donated blood is the lowest since 2015 right now, thanks to the COVID crisis.
Actually, that's during COVID. We're still in COVID, but I would say about 6 months ago, even more, it was so dire that we were actually many times out of blood, meaning I would have one bad trauma patient and I didn't have enough blood for the next one. So it's a horrible place to be in, to be thinking twice, should I give this person blood or are they going to die no matter what? I don't ever want to be in that situation. And there are a few times where I get a phone call and somebody's telling me, we don't have a lot of blood. So then, luckily or unluckily, this situation may arise, and they do rise and they do come, and it is a problem. And we do take things into granted thinking that, oh, we have blood available, but right now there is a huge shortage of blood. I implore and ask anybody that can donate to go ahead and donate.
This is just wonderful. Please keep going. You doing okay? You want a sip of water?
I do want a sip of water. Let me just get one.
Well, yeah, please do. In the meantime, I ask everybody to please put your questions into chat. We'll be happy to answer them as we go forward. While Dr. Huss is away from us, there's so many important things that we're hearing here. The Glasgow Coma score, EVM 456, the speed of an abnormal pulse below 60 or above 100. Always beware a patient with a tachycardia. There's something wrong with them. The crisis we're having in blood banks right now. So just terrific stuff that we're hearing tonight. Are you volume resuscitated, Nir?
I'm fully resuscitated.
Please continue. This is terrific.
So there are just a few things that I believe in that I always tell my residents and medical students, kind of little tenets. I think everybody has them. So I just wrote down a few of them that I try to go by, and that is, and I learned kind of along the way, always do the right thing. When you do the right thing, you're not going to be wrong. Meaning, as long as your intentions are pure and you do the right thing, then chances are that the right outcome is the one that's going to arise. And sometimes you can do all the right things and the patient still dies. And, I'm not a God and not everything is in my control, but at least do the right thing and be honest with the family. The other thing is, in medicine, everything we say or do matters, and it does have consequences, and it goes to the little smallest things. Changes in dosage of medication may mean oftentimes someone's living or dying, maybe even not today, it may be sometime in the future, but there is an effect. And then third is choose a field you love, you'll never work. I know that this is a cliche that a lot of people have heard, but I think medicine is so stressful overall. And we spend so many years in school just obtaining that degree and then having the privilege to practice it and do it, that I believe you have to do it for the love of it, because otherwise you're just not going to be a happy person. So the other thing is that medicine really affords the ability to have so many different fields. It's so wide that you should be able to find something that you really truly love, and then it's not work. And then don't let your ego get in the way. I think people get into problems and get into trouble when their ego is larger than it should be, in a sense that you can learn something from everyone. Today I learned from a medical student that there is no K in Portuguese. I had no idea. It doesn't really mean much, I guess, in my life, but I'm sure at some point it'll count for something. So you can learn something from everyone. And last thing is read, and stay up to date. I mean, I can't stress that also enough, because medicine changes in such a fast pace. There's no way you can read everything. There's no way you can know everything, but at least try. Read something every day. As long as you read something every day, that's something more than what you knew yesterday.
Nir, I tell my residents at Parkland that if I come to a patient and I don't know something, it's because I never knew it, and there's plenty of that, or I forgot it and I'm getting old. There's plenty of that. Or it's something new, and there's plenty of that. So you don't go into a healthcare career unless you're planning to do, among other things, a lifetime of study. And when you stop studying, it's time to get out.
Yeah. You never stop being a student. That's actually, I think, for me, why I love working with residents and students, is the fact that also drives me to continue to learn, to continue to be up to date, to make sure, because I'm looked upon to disseminate information. I want to make sure I'm disseminating correct information.
So you're in the trauma unit, and they bring in a middle-aged guy who is an IV drug user, hepatitis C, AIDS, methamphetamine abuser, who is in jail and is there because he attacked the guards, and he has been beaten for the guards protecting themselves, and comes in now in shock and in real trouble. Will you treat him the same way as a preacher who comes in who has a congregation? Is it the same kind of same thing?
Absolutely. Absolutely. I believe in that 100% because I'm definitely not a judge and jury. And I don't know the complete circumstances of what has happened. I have dealt with many prisoners that were actually killers and murderers, and you don't exactly know at the time. Many people off the streets that I've taken care of, apparently I had no idea, but they were, wanted for murder, let's say. And everybody deserves the same. I'm not the judge, I'm not the jury. My job is to get them well to the best extent that I can, and I let somebody else deal with the rest.
Well, that's absolutely the truth. And one of the biggest problems in medicine, in all parts of medicine, whether it's physicians, nursing, paramedics, or whatever, is burnout. So how long have you been a trauma surgeon near?
12 years.
And are you anywhere near burning out?
No, I don't feel that. Not even the closest. I do about 6 calls a month. Okay, so that means 6 24-hour what do you call it? 6 24-hour shifts a month. The next day I may have let's say general surgery day where I may have a number of surgeries. So I may be running about 30 hours, sometimes 36 hours. And I do not feel burned out, not even the slightest. I think, again, that is part of it. It's not for everyone. And I don't recommend it for everyone, but I do recommend it for somebody that has that feeling, and different people work in a different way. And it's okay. I know sometimes it sounds kind of crazy, but there are actually being studies on proficiency of surgeons, let's say after a 24-hour shift. And interestingly, they may not be able to drive, okay, but they can operate. And that has been shown. There is actually data to that extent, which is quite interesting. I don't say that this is optimal, and I do take breaks. I do rest as needed. If I feel tired, I will not operate. I actually have no shame, and I think it's important. I let the patient know. I say, listen, I am too tired. And if you don't mind, I have partners. They can do the surgery, and we all work together. I'm going to sleep. If you're adamant on me being your surgeon, it's okay. We can do it tomorrow, unless it's an emergency, and then me or my partner will do it no matter what. But I think everybody needs to know their limits and act accordingly. And the key is, again, to realize that there's a life in the hands. I love working with children. The other thing in trauma is we go ages 0 to whatever it is. I mean, I've operated on a 103-year-old, and I've operated on a 27-week preemie, that had, I just discussed this the other day with one of my colleagues, that I had a patient that was born 27 weeks and was basically a traumatic type event, as they were born breech, and their liver was bleeding. So it was a very interesting and unusual case to deal with a bleeding liver on a 27-week-old preemie baby. The size of the liver was the size of a chicken liver. It was this big. And the girl did well. She was months in the hospital, but she left the hospital, and it's been many years now, and I know she's somewhere doing very well. I'm sure of that.
Nir, you've got 300 pre-health kids listening to you at this moment. And if you were going to send a message to 18, 19, 20-year-old kids that are trying to get into a career in medicine, nursing, PA school, NP school, what message or two would you want to send them in this era, the smartphone era? They have all the information in the universe available to them in their pockets. What decision making would you send along with them? And I'm sorry to reach into your brain for this, but this is the kind of stuff we'd really like to hear.
I think that one of the issues that I see with the phones is distraction in learning. I think there is something that is being missed when we are constantly being bombarded and so accustomed to reply and not have that phone ever off, that I think does take effect into making the learning a little bit more difficult. And I think that those that do better have better learning habits where they actually do set time and somehow resist the urge to touch the phone. I think that is one of the key issues that in learning situation that is problematic. I know there's a lot of competition right now to get into there always is or was, and I think it's even more so now than maybe 20 years ago for all sorts of reasons. I mean, I think, for example, COVID, I know has increased the number of applicants to medical school or PA school or nursing school, etc. So
yeah, probably about 20% actually.
Yeah, it's not a negligible effect. So therefore, it feels a lot more competitive. It is a lot more competitive, but at the same time, I do feel that if somebody feels that this is what they want to do, shadowing is definitely one way to kind of flush out whether this is something you really want to do. And if it's something you really want to do, then pursue it. It may not be the first attempt that you will be able to get into medical school or PA school, etc. It may be the second, the third, or the fourth. And there's no reason to hurry. It's not the end of the world if you're, not going directly from college to medical school. There are a lot of things in between that are just as valid and important to your overall health as a human being. And it's okay sometimes to take a few years off. You may not be ready for many reasons. It may not be grades. There are many aspects that take a person to be, to the medical field and to be successful in the medical field, especially since it's extremely stressful. There are many stressors from hospitals and administration and insurances and you want to be a little bit more mature eventually to be able to deal with all this and not be burned out. So.
Nir, you got enough energy for a couple of questions from the students?
Sure.
Okay, Rohit, take it away.
Sure. One question the student said is, what's the average amount of time that you spend assessing a patient as a trauma surgeon? Like the moment they come in, how much time do you spend just trying to figure out, okay, what's going on, and then making a plan from there?
I try to limit it to less than 15 minutes. And if I'm going to the OR, we try to make sure that it's somewhere between 20 to 30 minutes, meaning 20 to 30 minutes in the trauma bay, and then leaving to go to the operating room.
Thank you for that. Another question is, earlier you were talking about the one patient who is clinically dead for 20 minutes. And so one student asked the question, how do you decide when to stop attempting to save someone?
Okay, so that's actually a tough decision, because sometimes, and it's what I see in a person, meaning if I have a person that is severely injured and I think that they're not going to survive, but maybe their body will survive, for example. If I'm not able to provide enough oxygenation for their brain, but there may be enough that even though they're brain dead, the body does survive, then that person may be able to save 4, 5, 6 other people by donating their organs. So I try to err on that possibility that there may be an organ donor and try to push it as much as possible until the point that I know this is medical futility. So that being said, it's not specific to a specific time. It's specific to the injury as a whole, to the brain versus the body. And I try to give everybody the benefit of the doubt. I also don't know the wishes of anybody when they first come in. Some people, let's say, will not want to live being quadriplegic, where others would want to leave no matter what. Some people will not want to leave being connected to a breathing machine for the rest of their life. And other people will say, you know what, this is something I am willing to accept. So initially, all these are unknown. I don't know that person. I don't know their family. I don't know their wishes. Then I try to do the best to resuscitate, to keep them alive. And I will stop when I believe it's medical futility.
Thank you for that answer. Another question is in the same vein. How did you deal with the first time you lost a patient?
So the first time I lost a patient, actually, we had this, every time there's a person that is being born, you have a twinkle, twinkle little star type of music in the speaker system. And I remember very distinctly that when I lost my first patient, that thing came on. So at the same time that I lost a patient, a little baby was born, which kind of helped me out that, it's like the whole circle of life. There's one life lost here, another one is gained over there. The most important thing for me is, again, I don't know anything about that person. So you may think it's difficult to connect, but then you talk to the family, and this is the moment that you realize what was either lost as a person, that although I don't know, I can still feel for them. And it's horrible. I can't say it's a good time, but it's definitely something that you have to learn to deal with. It's always a difficult situation. It's always difficult when it's a little baby versus, let's say, someone who's 90 something years old. Obviously, there is a difference. It's tough.
Thank you for sharing that. And then one last question from me, I think.
Oops.
Because there's so many people working in the operating room.
I don't have an answer for that. Is there something else I can help with?
Anyhow, restarting that question.
That was Siri, I think, trying to answer this question.
Since there are so many people working in the operating room, how do you go about with differing medical opinions on trauma cases? And how do you get the whole team to agree to one plan and work with that?
So the day that I'm on call, or one of my colleagues is on call, each one of us is the designated trauma surgeon that day. Whatever that person says, that's what goes. Now, that being said, once a month, we take the time to actually sit down and go through basically every case. There's a team behind the scene that, God bless them, they do a lot of hard work to read everything that we write, to look at everything that the nurses write, to look at the record and look for errors. Sometimes to the point of being annoying, but it's important. And then we bring out every case, literally every case, and it gets discussed ad nauseum among all the trauma surgeons, the chief nursing staff, there's administration involved, the radiologist, the neurosurgeon, the plastic surgeon, the orthopedic surgeon. It's a whole team. But we go through every case and every issue and every potential problem and every problem that did occur, every problem that may occur, and come up to some sort of a consensus. Well, I would have treated it this way, and discuss it. And it's done once a month, and it's an important part of it. And this is one of the things how we learn and come to a consensus of how we treat certain things.
Nir, what a wonderful answer. God, your spirit is just amazing. And I want all of the students, please look at the chat. I want all of the students put thank you so much into the chat, so you can see almost 300 students putting thank you in right now. Just very, very much appreciated that. And just please see this abundance of outpouring of gratitude from all these students all around the world, Nir. So thank you so much.
Thank you, guys.
Rohit, do you want to tell them about the quiz?
So here's the information for assessment number 72. So this will be due at 6:59 p.m. Central Standard Time next week, just before the next session starts. You have 2 attempts to get a 70% or better, and please download the certificate. Here's the QR code, which you can scan with your phone, or if you'd like the link, here it is down below, and this will also be sent out in our weekly email.
Nir, we want to thank you again. This is just tremendous. At least 5,000 people will watch this online with us. You had 300 tonight. Each of those 5,000 in a medical career will see 100,000 patients. 5,000 times 100,000 is 500 million. You will have touched 500 million lives through this talk that you gave tonight. So we are deeply, profoundly grateful for you taking this time away from your practice and from your family to come share your thoughts with us. And they meant a great deal. Well, everyone, we want to thank you for coming. We're here every week. It's been a year and a half. This is talk number 72. And if you keep coming back, we're going to be here. So on behalf of the whole virtual shadowing team and Dr. Nir, and just all of us out here, we want to thank you for coming. And we wish you a good evening and a good night. Thank you.
Good night, guys, and thank you for the opportunity.